Welcome to the Health Headliner podcast by Tudu Digital. Our content is informational only and not medical advice. Please consult your provider. Now, let's dive into today's headlines.
Welcome to the deep dive. If you've been following the AI space, especially in medicine, you've probably seen some pretty startling headlines.
Oh, absolutely. These large language models, systems like GPT-5, Gemini 2.5 Pro, they're scoring incredibly well on medical exams.
Like top-of-the-class scores, passing medical boards, outperforming human students sometimes. It really makes you think, okay, they're ready for the clinic.
On paper, yes. The performance looks phenomenal, but that's exactly what we need to dig into today.
Exactly, because the real question is what happens when things get messy? You know, when you move from the clean, predictable world of a benchmark test to the actual chaos of clinical practice.
What happens when data is missing, or ambiguous, or just unexpected? That's the critical test.
And that's our mission for this deep dive. We're unpacking some really crucial research from Microsoft Research, specifically their Health and Life Sciences division. They put these top-scoring models through a rigorous stress test.
And their findings are, well, quite sobering. The big takeaway: these systems are, and I quote, not ready to see you now.
It's a stark conclusion. We've got the original health news analysis and, crucially, the scientific paper itself. It details how these high scores can hide some really dangerous weaknesses, things like brittleness, shortcut learning, even fabricated reasoning.
Which really forces us to rethink what readiness even means in healthcare. It's not just about getting the right answer sometimes, or even most of the time.
No, in medicine, you need reliability under pressure. You need trust.
And that trust has to be built on robust performance when things aren't perfect. It requires understanding the reasoning, knowing it's valid, knowing it's actually based on the evidence presented.
So we're shifting the focus here, aren't we? It's not just if the AI gets the right diagnosis.
It's how. Is it genuinely understanding the clinical picture, or is it just exploiting patterns in the data? Because if it's the latter, that correct answer isn't really reliable, is it? Not when a patient's health is on the line.
Okay, so let's talk about that illusion. There's so much hope pinned on medical AI making diagnostics cheaper, faster, more accessible. But the researchers point out a kind of credibility gap.
Right. Achieving those goals depends entirely on critical accuracy, on genuine understanding. And the argument here is that our current tests, our benchmarks, they're not actually measuring that.
They're rewarding something else.
They're rewarding pattern matching, essentially.
Yeah.
Statistical correlation. The AI gets good at knowing what answer usually follows what input pattern in the training data, but not necessarily why in a deep medical sense.
Which brings us to this key concept they identified, shortcut learning. Can you break that down for us? What does that look like, especially when you've got both text and images, like in many medical cases?
Sure. Shortcut learning is basically the model finding the easiest way to the answer, even if it means ignoring crucial information. In a medical context, imagine a case with, say, a chest X-ray image and a text description.
Okay.
The text might list symptoms like productive cough, fever, recent travel. The AI, having seen thousands of similar cases, knows this pattern often correlates highly with, let's say, atypical pneumonia.
Right, statistically.
Exactly. A human doctor uses that text, but then critically examines the X-ray image, looks for specific visual signs like infiltrates, their location, density pattern, to confirm or refute the diagnosis.
The AI taking a shortcut might skip the image analysis.
Precisely. It sees the text cues, recognizes the statistical pattern, and jumps straight to atypical pneumonia because that's the most probable answer based on its training data, without genuinely interpreting the visual evidence on the X-ray, even if the image is ambiguous or maybe even contradicts that diagnosis.
Wow. So it's like finding the path of least resistance, relying purely on past correlations.
That's a good way to put it. It exploits the data structure instead of building a flexible evidence-based reasoning process.
And here's the really concerning part the study highlights.
Go on.
The newest models, the ones scoring highest on standard benchmarks, might actually be more brittle, more prone to these shortcuts when faced with real-world fuzziness, uncertainty, missing data, even slight changes in how the question is phrased. So they're getting better at acing the test, but not necessarily better at actual robust medical reasoning.
It seems that way. The underlying vulnerability remains, perhaps even masked by the high scores. It's like they've mastered the test format, not the underlying subject.
It sounds almost like a very sophisticated form of memorization or pattern regurgitation. So to really pin this down, what models and tests did the researchers actually examine? What was the scope here?
They really went for the big players. 6 cutting-edge, commercially relevant models. We're talking GPT-5, Gemini 2.5 Pro, GPT-4o, among others, the very systems people are looking to deploy.
And the tests.
They used 6 different multimodal medical benchmarks. And critically, these weren't just simple image labeling tasks. They included complex clinical cases, the kind you'd find in teaching materials from top journals like the Journal of the American Medical Association, JML, and the New England Journal of Medicine, NEJM.
So really challenging stuff designed to test deep diagnostic skills.
Exactly. These are often multi-step problems, clinical vignettes that require synthesizing different pieces of information, much like a real doctor would. They were testing if the AI could act like a consultant on complex cases.
Okay, so if those high scores are potentially an illusion built on shortcuts, the researchers needed a way to expose that, right? To break the shortcuts.
Yes, and they developed this tiered stress testing protocol. It's designed specifically to mimic the kind of ambiguity and missing information you get in the real world.
Let's walk through it. The first stress test sounds fundamental. Modality sensitivity. Trying to figure out what part of the input the AI is actually relying on, the text or the image.
It's arguably the most direct test of whether the AI is truly integrating different types of information. Think about a typical multimodal clinical question. You have the patient's history and symptoms in text, plus a key image like a CT scan, an ECG, maybe pathology slide.
Right. Both pieces are usually important.
They should be. So the test asks, how much does the AI really rely on each part? If the image is supposed to be critical, but the model gets the right answer using only the text, well,
that smells like a shortcut.
Exactly. It's strong evidence of shortcut learning.
So how did they test this? What was the method?
Simple, but very revealing. They took these multimodal questions, the ones with both text and an image, and they just removed the image entirely.
Okay.
Then they compared the accuracy score the model got with just the text to the score it got with the full input, the text plus the image.
And what did they find? Did removing the image make a difference?
Oh, it made a huge difference, but in revealing ways. The results immediately showed big inconsistencies, especially between different benchmarks. When they looked at questions from the New England Journal of Medicine, NEJM.
Which you said were known for being visually demanding.
Right. Those NEJM items often require complex visual interpretation and reasoning. And on those, removing the image caused sharp drops in accuracy. It confirmed these questions genuinely need the visual input.
Can you give an example?
Sure. For GPT-5, accuracy fell from about 81% with the image down to roughly 67.5% without it. That's a big drop, over 13 percentage points.
Wow.
And Gemini 2.5 Pro dropped even more steeply from nearly 80% down to just 65%, a fall of almost 15 percentage points.
Okay, so for those NEJM questions, the models were using the images significantly, which seems good. Appropriate, at least.
It suggests the visual modality was indeed contributing significantly to the correct answer on those specific visually complex items. But then they looked at the items from the Journal of the American Medical Association, the JMA items.
And what happened there?
The results were surprisingly stable. The accuracy shifts were, well, pretty modest when the image was removed.
Modest.
For GPT-5, it only dropped about 3.7 percentage points. It still scored over 82% correct using just the text.
Wait, so on the JMA questions, taking away the image barely mattered for these top models?
Largely, yes. And this tells us two really important things. First, models that look similar on an overall score can behave very differently when you probe them like this. It exposes hidden differences in how they actually process the information.
And the second thing?
The second, and maybe more critical point for how we evaluate AI, is that many of those JAMA items were fundamentally solvable from the text alone.
The image wasn't strictly necessary?
Apparently not for many of them. The text must have contained enough clues, maybe detailed lab results, specific patient demographics, keywords in the history that allowed the AI to figure out the right answer without needing to truly analyze the image.
That really undermines using an aggregated score across benchmarks, doesn't it? You're averaging performance on genuinely visual tasks with tasks that are secretly text-based puzzles?
Precisely. If your goal is an AI that helps with visual diagnosis, like reading scans, testing it on benchmarks that can be solved without looking at the pictures gives you a totally false sense of its visual capabilities.
Which naturally leads to the next stress test, right? Trying to isolate questions where the image is definitely needed.
Exactly. That was stress test 2, modality necessity. They wanted to close that loophole, to focus only on questions where the visual information was absolutely essential.
How could they be sure the image was essential?
They didn't just guess. They brought in expert clinicians. These doctors reviewed the NEJM benchmark items and curated a specific subset, 175 questions, that they confirmed absolutely require looking at the image to answer correctly.
So for these questions, if you only had the text, even a skilled human doctor would likely be guessing.
Pretty much. The clinicians agreed that without the visual data, performance should be only slightly better than random chance. Since these were multiple choice questions with 4 options, random chance is 20%.
Okay, so they have this set of questions confirmed by experts to need the image. Then they ran the test again, gave the models only the text for these specific questions.
Yes, remove the image again for just this expert-curated, visually necessary set.
And the expectation was the score should plummet towards 20%.
That was the hypothesis, if the models were relying solely on genuine visual understanding. But that's not what happened.
What did happen?
Even on these clinically validated visual necessity questions, most models still perform significantly above that 20% random chance and baseline when they only got the text.
Like how much above?
GPT-5 scored 37.7% correct. Gemini 2.5 Pro was right there too at 37.1%, nearly double the performance you'd expect from random guessing.
So even when human experts said, you cannot answer this without the image, the AI was still getting it right over a third of the time using only the tech.
Correct. And that finding is probably the most direct, damning evidence of shortcut behavior in the whole study.
How so?
Because if a human expert can't reliably answer without the image, but the AI scores almost 40% using just the text, it cannot be deriving its answer from genuine medical understanding of the case as presented. It must be relying on something else.
Yeah.
Things like artifacts in the data set it was trained on, learned frequency priors, basically, knowing that certain symptom combinations in the text usually lead to a specific answer, even if that's not justified in this particular case, or maybe even just memorize question-answer pairs from seeing similar text descriptions during its massive pre-training phase.
So it's making incredibly sophisticated statistical guesses based on the text patterns it has learned rather than actually doing the visual diagnosis work required.
That's the strong implication. It's gaming the structure, not understanding the medicine.
This is deeply concerning. It means the model might seem right, but for totally unreliable reasons. I did notice one model behaved quite differently here. GPT-4o scored really low, only 3.4%, without the image on these necessary questions. Why was that?
Ah, yes, the GPT-4o anomaly. That's a fascinating result and sparked some debate. The reason the score was so low wasn't necessarily because it was worse at guessing. No, it was because it frequently refused to answer. When it was faced with a question that clearly needed visual information, and that image was missing, GPT-4o often explicitly abstained. It didn't pick one of the multiple choice options.
So refusing to guess actually hurt its score in the benchmark calculation.
Exactly. Mathematically, refusing counts as incorrect, so its accuracy number plummeted. But the researchers raised a really important point. Maybe this refusal behavior is actually a good thing.
How so?
Well, clinically, isn't it better for a system to say, I don't have enough information to answer confidently, rather than making a potentially dangerous guess based on incomplete data?
Absolutely. Knowing your limits is crucial in medicine.
Right. So while GPT-4o got a lower score on this specific test, its behavior might reflect a more cautious, appropriate kind of uncertainty handling. It's a sign of potential safety alignment, even if it doesn't maximize the benchmark score. It's that difference between confidently guessing wrong and knowing when to say, I don't know.
Okay, so we've established these models can lean heavily on text shortcuts when visual data is missing or weak. But the researchers went further, didn't they? They started messing with the structure of the test questions themselves.
They did. This next set of stress tests involving input perturbation was really about seeing just how superficial some of these learned strategies are. It wasn't just about missing data anymore, but about whether the models were sensitive to the format itself.
Let's start with stress test 3, format perturbation. This one sounds almost basic testing if the order of the multiple choice answers matters.
It does sound basic, maybe even a bit absurd for such advanced AI. But remember, these models are fundamentally pattern recognizers. They were testing if the models relied on the fixed position of the answer. Options like maybe option B was statistically more likely to be correct in the training data, or perhaps some subtle pattern in the token sequence of the choices.
It's hard to fathom a sophisticated medical AI being thrown off by just shuffling the A, B, C, D options.
Yet the results showed it could be a factor. They simply randomize the order of the answer choices, keeping the actual text of the answers the same.
And this had an effect.
Yes, particularly again in that text-only setting, where the visual anchor was gone. Randomly reordering the options caused noticeable drops in accuracy for several models.
Like with GPT-5.
For GPT-5, in the text-only scenario on those visually necessary questions, its accuracy dropped from that 37.7% we talked about down to 32.0%.
Just from shuffling the answers.
Just from shuffling the answers. It's pretty solid evidence that when the primary visual input is missing, the models can fall back on really superficial cues like the format or position of the answers. It suggests they've internalized some fixed format patterns from their training data, or maybe from previous benchmarks they've encountered.
So, deprived of visual grounding, they cling to any pattern they can find, even the layout of the multiple choice options.
It seems that way. The visual signal, when it's strong and present, usually overrides these weaker, shallower text or format heuristics. But take away that visual anchor, and the model reverts to the easiest statistical pattern it knows.
Okay, moving on to stress test 4. This one targeted the reliance on learned question option patterns more directly. Distractor replacement. What was the idea here?
The goal was to see if the model truly understood why the correct answer was right, or if it was just good at recognizing the usual wrong answers, the distractors, and eliminating them.
How did they test that?
They systematically replaced the incorrect answer options, the distractors, with choices that were totally irrelevant or medically implausible. The correct answer stayed the same and was still correct.
So, if the model genuinely understood the medical reason for the right answer, making the wrong answers more obviously wrong should make the task easier, right? Accuracy should go up.
Logically, yes. If you know the answer is X because of specific evidence, swapping out incorrect options, Y and Z, for completely nonsensical options shouldn't confuse you. It should make selecting X even easier.
But what actually happened, especially in the text-only setting?
Accuracy actually went down. As they replaced more distractors with irrelevant ones, the model's performance declined toward the 20% random chance level.
Seriously. Making the distractors less plausible made the models worse.
Yes. For instance, if you replace all 4 incorrect options with irrelevant ones in the text-only scenario, GPT-5's accuracy hit exactly 20% pure chance.
What does that tell us?
It strongly suggests the models aren't working from first principles to identify the correct answer. Instead, they rely heavily on learned associations between the question and the specific set of plausible distractors they usually see. They need those familiar wrong answers to be present to run their elimination process. Take away the familiar context, even by making the wrong answers more wrong, and their strategy falls apart.
They've learned a pattern involving the whole question and options block, not just the question to correct answer link.
Exactly. They need the usual suspects lined up to identify the outlier. But then came a really fascinating twist within this test, what the researchers called the unknown paradox.
Okay, I'm intrigued. What happened with unknown?
Instead of replacing a distractor with something irrelevant, they replaced just one distractor with the literal token unknown.
How would you expect a system to handle that? A human might see unknown as a signal of uncertainty, maybe a prompt to reconsider or abstain if unsure.
Right. You'd think the model might ignore it, or perhaps if it aligned with the model's own internal uncertainty, it might even select unknown. But that's not what happened.
Don't tell me accuracy went up again.
For several models, yes. Replacing just one plausible distractor with the word unknown actually improved their text-only accuracy. GPT-5, for example, went from that 37.7% baseline up to nearly 43%.
That's bizarre. Why would adding unknown make it easier?
The interpretation is that the AI didn't treat unknown as a signal of uncertainty or a valid option in itself. It treated unknown as just another distractor, but a weak one.
Like an obviously or wrong answer that's easy to eliminate.
Exactly. It essentially thought, this unknown option is clearly not the complex medical diagnosis I'm looking for. It's easier to rule out than the original, plausible but wrong answer it replaced. Therefore, my odds of picking the correct one from the remaining options just went up.
So it's applying pure test-taking strategy, like a student crossing off the easiest wrong answer first, rather than engaging with the meaning of unknown in a clinical context.
Precisely. It's hyper-efficient elimination logic, completely divorced from appropriate clinical caution or genuine uncertainty handling. It's another profound indicator that these models are optimizing purely for the test score, finding the path of least resistance within the test structure, rather than aiming for robust, clinically meaningful understanding.
Which sets the stage perfectly for the final and perhaps toughest perturbation test. Stress test 5, visual substitution. The counterfactual test.
Yes, this was designed as the ultimate test of genuine multimodal integration. Could the model handle a direct conflict between the text and the image?
How did they create that conflict?
This was quite clever. They took a question where the text and the original image pointed to the correct answer, say answer A. They kept the text exactly the same. They kept all the answer options, A, B, C, D, the same, but they swapped out the original image.
Swapped it with what?
They replaced it with a new image that visually aligned perfectly with one of the distractor answers, say answer B. So now the text suggests answer A, but the visual evidence strongly points to answer B.
Okay, so a direct contradiction. What should a robust integrated model do?
A truly robust model, capable of genuine visual textual reasoning, should see the new visual evidence, recognize the conflict, and ideally revise its prediction based on the strong, unambiguous visual input. It should likely switch its answer from A to B.
And what actually happened when they introduced this cognitive dissonance?
It was a meltdown.
Yeah.
Accuracy collapsed across the board.
How bad was the collapse?
It was dramatic. When the visual information explicitly contradicted the answer suggested by the text, which the model likely favored due to pattern matching or memorization, performance plummeted. GPT-5's accuracy dropped from 83.3% on the original questions down to just 51.7% on these substituted image versions. That's a massive 31.6 percentage point fall.
Wow. Over 30 points just from changing the image to match a wrong answer.
Yes, and Gemini 2.5 Pro fared even worse, dropping by 33.3 percentage points.
A failure of that magnitude really suggests a fundamental breakdown, doesn't it? Not just a minor glitch.
Absolutely. It indicates the model's success on the original multimodal questions wasn't based on flexible integrated reasoning. It was based on brittle, likely memorized pairings between certain textual descriptions and certain visual features or labels.
So when that expected pairing was broken, when the image didn't match the text statistical prediction, the system couldn't cope.
Exactly. The model couldn't reconcile the conflicting signals. The memorized text-based association clashed with the new contradictory visual evidence, and the whole reasoning process just fell apart. It confirms the reliance on brittle shortcuts rather than genuine synthesis.
Okay, so we've seen the models struggle with accuracy when shortcuts are disrupted. But getting the right answer isn't everything in medicine, is it? The why matters just as much, maybe more. Clinicians need to trust the reasoning process.
Absolutely. You can't blindly trust a black box, especially in high-stakes decisions. That's why stress test 6 was so important. Reasoning signal integrity, asked. Even when the models try to explain themselves, is that reasoning actually sound, or is it just made up?
They often use techniques like chain of thought prompting, now asking the AI to show its work, basically. Did that help?
The findings there were quite revealing and maybe counterintuitive. For the biggest, most advanced models, explicitly asking them to provide step-by-step reasoning often didn't improve accuracy. Sometimes it actually made it worse.
Forcing them to explain themselves made them less accurate.
For some of the top models, yes. It suggests that the explicit reasoning process isn't necessarily driving the answer in these systems. It might even be a kind of distracting overlay, rather than the core computational engine leading to the result. Adding that scaffolding didn't inherently fix the underlying issues.
Okay, so chain of thought wasn't a silver bullet. What about the quality of the explanations themselves? They did a manual audit, right? Looking closely at the reasoning provided.
Yes, and this manual analysis uncovered perhaps the most concerning failure patterns. This is where you see how these systems can appear confident and logical while being fundamentally wrong.
What kind of failures did they find?
One major pattern was correct answers, but with incorrect logic. The model would arrive at the right diagnosis, but the explanation it gave was factually wrong, sometimes wildly so.
Can you give an example?
It might correctly diagnose pneumonia, but then confidently justify it by saying, this is based on the clear consolidation visible in the superior lobe of the right lung. When you look at the actual image provided, and the superior lobe is perfectly clear. There's no consolidation there.
So it's literally hallucinating evidence in the image to fit the answer it already decided on, probably via a shortcut.
Precisely. It's retrofitting a plausible-sounding rationale onto an answer reached through other means. This leads directly to the concept of fabricated reasoning.
Fabricated reasoning, meaning the explanation is just made up.
Essentially, yes. The rationale sounded good. They used medical terminology. They referred to image regions. They followed logical seeming steps. But they confidently justified things that were either hallucinated, factually incorrect based on the provided data, or misinterpreted.
It effectively masks the shortcut behavior that likely led to the answer.
It mimics the form of clinical reasoning without the substance. Exactly. Another related issue was misgrounding. The model might correctly identify steps like examine region X, assess feature Y, but then it grounds that step on an incorrect or imagined feature within that region. So the structure looks right, but the content it's reasoning about is wrong, leading to a confident but incorrect conclusion or justification.
The danger here seems huge. It's not just getting a wrong answer. It's getting a potentially right answer accompanied by a convincing, detailed, but utterly false explanation.
That is the absolute core of the reasoning trap. The explanation generated by the model is often completely disconnected from any genuine, integrated multimodal understanding. The prediction might be right due to pattern matching, but the reasoning is unreliable.
And if a clinician trusts that reasoning, it could lead them down a completely wrong path, even if the AI's final answer happened, maybe by chance or shortcut, to be correct that time.
Precisely. If you can't verify how the AI reached its conclusion, if the explanation itself is potentially fabricated or misgrounded, then you simply cannot trust the prediction in a clinical setting. The reasoning signal itself is compromised.
This whole investigation paints a pretty stark picture. It makes it incredibly clear that the problem isn't just the AI models themselves, but also the tests we're using to judge them.
That's a major conclusion of the research. We need to benchmark the benchmarks themselves. We have to get critical about what these evaluation tools are actually measuring.
Because they're not all the same, even if they get lumped together?
Not at all. The researchers working with clinicians analyzed the profiles of commonly used benchmarks and found they vary dramatically in the skills they test, even though they're often treated as interchangeable on leaderboards.
Can you give us a sense of those different profiles?
Sure. Take the New England Journal of Medicine, NEJM, items we discussed. Their profile is high on both reasoning complexity and visual demands. They really require intricate visual interpretation and multi-step clinical thinking.
Okay, NEJM is tough visually and logically. What about JAMA?
The Journal of the American Medical Association, JMA items, were found to require substantial reasoning, so they're complex logically, but as the stress test showed, many are largely text-solvable. Their profile is high reasoning, but low visual dependence.
And other common benchmarks, like ones focused just on visual questions.
Right. You have benchmarks like VQA-Array or PMC VQA. These tend to be highly visually dependent. You definitely need the image, but they often test simpler tasks, lower in inference complexity. Things like locate the fracture or what modality is this image? Simple Q&A tied to the visual.
So averaging scores across NEJM, GEMMA, and VQA-Array doesn't make any sense. It's like averaging apples, oranges, and, I don't know, textbooks.
Exactly. You get a single number that obscures these critical differences in what's actually being tested. A high score tells you very little about whether the AI is good at complex visual diagnosis versus complex text-based reasoning versus simple image description.
To fix this, the researchers proposed a more structured way to analyze benchmarks, didn't they? Using a clinician-defined rubric.
Yes, they outlined a formal framework to profile benchmarks along medically relevant dimensions. This offers a path toward much more meaningful evaluation.
What are the key dimensions in that rubric?
There are two main axes. First is reasoning complexity. This looks at things like how many steps are needed, how complex is the clinical context, is time or sequence important, what's the potential impact of the decision.
Okay, so how much thinking is required, and the second axis?
Visual complexity. This assesses, can the question be solved from text alone? What level of visual detail is needed? A quick glance or expert-level scrutiny? How sensitive is it to image quality variations?
Using a rubric like that seems essential for understanding what a benchmark score actually signifies.
It is, and based on this analysis, the researchers made some really concrete, actionable recommendations for reforming how we evaluate medical AI. This is the real so what. How do we fix this?
What are the key recommendations?
First, and maybe most importantly, treat benchmarks like diagnostic instruments, not just targets to hit. We need to understand and document their limitations, their failure modes, their inherent assumptions. If a benchmark is largely text solvable, that needs to be known and the score interpreted accordingly. It's not proof of visual skill.
Makes sense. What else?
Second, stop aggregating scores across diverse benchmarks. Leaderboards need to be disaggregated. Report performance separately based on these meaningful profiles, performance on high reasoning, high visual tasks versus high reasoning, low visual tasks, etc. Give us a nuanced picture, not a misleading average.
So context matters in the third recommendation.
Third, and crucial for tackling the brittleness problem. Evaluation protocols must routinely include stress testing. We need to measure robustness, how well models perform under pressure, with missing data, with perturbations, not just static accuracy on clean data.
Because without that stress testing.
Without it, we risk continuing to optimize models that look good on the current, flawed benchmarks, but remain fragile and potentially unsafe when faced with the complexities of real clinical practice. We'd just be reinforcing the illusion of readiness. #outro.
So wrapping up our deep dive today, the core message is pretty clear. Those impressive high scores we see from medical AI, they can be, and often are, an illusion of readiness.
Right. Real-world medicine demands more than just high average accuracy. It needs reliability, especially under uncertainty. It needs reasoning we can actually inspect and trust.
And these models, despite their advancements, currently seem to fall short on that front, largely because they rely so heavily on these superficial patterns, these statistical shortcuts. They've learned how to ace the test, but not necessarily how to practice medicine robustly.
And it's important to reiterate, as the researchers do, that this isn't about blaming the models for being malicious. Part of the problem is structural deterrence. Many benchmark examples are out there publicly, so models might unintentionally memorize them during their vast pre-training.
So even as models get technically better generation over generation, this underlying brittleness, this tendency to exploit shallow cues like formatting or word co-occurrence, seems to persist.
It does, and you see the models getting smarter, in a way, about the testing environment itself. They're optimizing for the test.
Which leads us to a really provocative final thought, doesn't it? These AI systems are getting better at spotting and exploiting the weaknesses in how we test them. Remember how they treated unknown as just an easy wrong answer? Or how they relied on answer order?
Exactly. They're learning the test's quirks.
So if these systems keep optimizing for the test structure itself rather than for genuine clinical understanding, how long before the AI systems are, in effect, gaming the evaluation so effectively that they dictate what readiness looks like rather than us? Are they designing the tests they know they can pass?
That's the profound challenge this research throws down to everyone developing and evaluating AI in healthcare. It suggests the future of building trustworthy medical AI might require a constant evolution in our testing, maybe continuous adversarial stress testing, where the tests get harder and change faster than the models can adapt their shortcuts.
A constant arms race between the models and the tests.
Perhaps. At the end of the day, we have to shift our demands. We need evaluation methods that insist these AI systems succeed for the right reasons, with reasoning that is transparent, verifiable, and grounded in solid evidence. Because when it comes to healthcare, the stakes are simply too high to accept an illusion, however convincing it might seem. We need true reliability.
Thanks for tuning in to the Health Headliner podcast by Digital. Like and subscribe for more health news and breakthroughs. Stay healthy and informed. See you next time.